So I'm going to introduce Claire, our second speaker for today, and she's going to be talking about the process of co-creating Dragons of Afterlands, which is a board game for adolescent skill development with augmented reality. So introduce Claire quickly. So she's the project lead at Playful for Life, and she applies her background in education and health psychology and adolescent development. And she's previously served as curriculum team lead for psychology, head of sixth form, health coordinator, getting lots of experience in teaching in pastoral care. She holds an MSc in health psychology and is currently pursuing a doctorate in health psychology at UE. And her research is primarily focused on adolescents living with chronic illnesses. So without further ado, do you want to time?
All right.
At least a clicker, which hopefully should work.
It's fine. I'm old school. You can. No. Nor does the keyboard actually.
Should work now. Hopefully. Yeah.
Yes.
Nice.
And this board.
Perfect. Thank you. So that was everything that I could have possibly said about myself. You know who I am now. I do have slides because I was a teacher and that's my comfort blanket. But now I feel like a complete mug because I made them myself rather than use AI. So there's an error. So yeah, I am going to talk to you about Dragons of Afterlands. The kind of adolescent focus, I suppose, as Matt said, most of my research is about adolescents with long-term conditions or chronic conditions, physical ones. Done an alarming number of systematic reviews about the transition process from paediatric to adult healthcare, where lots of adolescents kind of fall off the radar, and there's obviously implications of that. The research side of that and thinking about, okay, what can we do then to kind of keep adolescents engaged with healthcare as they transfer to those adult services, then started to kind of feed into the Dragons of Afterlands side of things when we were looking at, okay, using it in schools, whatever, and then actually that adolescent gap in the NHS is not just for those with chronic conditions as they transfer to adult care, it's for any adolescent coming into contact with any healthcare provider. There is a feeling of kind of being in limbo. So I will talk a little bit about that as well. This is the problem. This is why we're here. These are the kind of statistics that we're dealing with. So young people with chronic physical conditions are 60% more likely to present with a mental health condition by age 15 than their peers without chronic physical health conditions. This bit here about EBSA is relevant because most of the young people who are not in mainstream education for anxiety are being taught through hospital schools. So lots of alternative provision is run by hospital schools. So for example, here it's Bristol Hospital Education Service. So it's not just teachers on wards delivering education to those people who are in hospital. It's also people who are kind of in their bedrooms because they're too anxious to leave their bedrooms. So there's a real crossover in terms of who we're dealing with here. And obviously you can imagine that people who are in hospital for either a long kind of extended period of time or who are regularly in hospital for chemotherapy or transfusions or whatever are missing out on lots of stuff going on with their peers, not just their education, but also that kind of social integration. So essentially what we have found through lots and lots and lots of conversations is that any adolescent who is not in mainstream education, and my thoughts on mainstream education are an entirely different talk, but if they're not in mainstream education, they are falling through the cracks. So we are then relying on motivated staff who are going above and beyond their job descriptions and usually above and beyond their hours as well to try to engage these young people, whether that's on a ward, whether it's in an alternative education setting, wherever it is. Those staff don't have the tools They don't have the spaces. We've heard lots and lots of the hospitals that did have adolescent-specific spaces. A surprising number of those were the ideal target for, oh, we need to create an extra staff room during COVID, or actually we don't have enough staff to run all of our areas. That's the one we'll close. So even the places that did have the physical adolescent spaces have kind of lost those recently. And there's also not adolescent-specific training for staff working with them. So there's child development, but it very rarely looks at adolescents. So this is the issue. This sounds like my issue now. So adolescent-specific spaces are a little bit out of our reach. Adolescent-specific training is something that at Play Well for Life we do deliver. And at the end, I will share a link to this, but we've also started a community of practice for anyone working with adolescents. So whether that is in education, healthcare, community projects, to kind of share experiences and skills, tips about working with adolescents. So the adolescent-specific training, I'm on it. And then this is the main point of this talk. So Dragons of Afterlands is an augmented reality board game. And it is an adolescent-specific tool. So it has been built specifically for, it's not a tool that's been adapted from a different audience. And again, I will talk in detail about the kind of co-production with adolescents later, but just to give you an idea of what the game is and what it's doing. Excuse me. You play as a dragon trainer. So the whole premise is you need to complete your egg mission that's given to you at the beginning by traveling around these 4 different realms. So the lava realm, forest, ice and whirlpool realms. And each one of those realms has a challenge tile in the corner. So when you land on it, you are doing a collaborative challenge. So although it's a competitive game, you have to collaborate with the other players to do the challenge. And each one of those is focused on a different area of well-being. So physical, social, emotional, and cognitive well-being that you have to complete to win the game, essentially. So the whole point of you being a dragon trainer is that it's all totally depersonalized. So you're not sitting with a young person going, oh, this is an interesting scenario. What would you do? How do you feel? What do you think? Because we all know that doesn't get us very far. So what you're saying is, oh, interesting. What does your dragon need to learn at this point? Or if your dragon did that, what might the consequences of their actions be? So it's all completely depersonalized. There are also other more board gamey elements, partly for fun, and partly for other kind of underlying psychological reasons. So monster battles are the thing that all young people just want to play if you let them choose tiles without rolling a dice. They are fun, but they are also encouraging young people to critically evaluate a situation. You know, is it advantageous to risk your health points now? Have you got the right kind of stat boost to battle that monster that you've ended up on? So there's a lot of kind of critical evaluation going on there. You can choose to fight with an ally. And if you choose to fight with an ally, that ally then gets the chance to say no if they don't want to, because we really believe it's important to be able to say no and to justify that and not, you know, not have to go along with something because someone said, oh yeah, you help me. So there's a little bit going on there as well. And there are then natural disasters and opportunity threats, which are more of the sort of game mechanics. Opportunity threats, a bit like a chance card in Monopoly. So you might be able to steal someone's egg, or you might get taken to a tile that's going to have a disastrous consequence. The challenges themselves, and you'll see this for people in the room who want to play it afterwards, the challenges themselves have some kind of psychoeducation built into the end of it. At the moment, that's quite wordy and we're refining it. But the whole point of that is that the staff who are facilitating the game can either choose to kind of skip through it if they're using the game more for kind of engagement and relationship building purposes, or they can kind of put the phones down for a bit and really engage with like, oh, this is interesting. Why might, you know, let's reflect and have a discussion. So it allows the staff to kind of use the game as they wish. We were just having an interesting conversation at coffee time about the kind of phones and physical element. We believe that's really important. So there's quite a lot of research showing that board games are an excellent learning tool. There's a lot of kind of serious game research, games for education purposes. The tech is engaging for young people. You know, most young people, if you say there's something on a screen, will go, okay, I'll have a go. But it's also that kind of bridge, and it allows us to have technically endless content. So rather than when you buy a board game with a box full of cards in it, and then you're like, oh, we've done all these scenarios, they're coming around again. What it means is we can feed endless versions through that. So I've waffled at you quite a lot about what it is. I'm going to try and show you a video.
Dragons of Afterlands is an innovative way to improve adolescent social and emotional skills using augmented reality.
You can patch an enemy and go on a quest to get more energy to run the game.
It's like an interactive game where you have a phone, you like point it towards the board, and you can see dragons and different characters on it.
And it's super interactive. You see all of the elements and all of the natural disasters that happen in real time.
Dragons of Afterlands is for 2 to 4 players and can be played in person together or remotely, meaning it's a tool that can be used to reach even the most disengaged and isolated and support reintegration.
I think if you're at a place where you don't really know people, you would get to know them. It's very fun to engage through a screen, but also having something in front of you that you can like roll the dice on.
Normal board games, it's kind of when it's kind of two-dimensional, it gets very repetitive and boring.
Yeah, it's like Dungeons and Dragons, but way cooler.
Co-produced with young people, educators and psychologists, it uses evidence-based psychological intervention approaches within the gameplay and is scientifically validated.
Absolutely brilliant. I loved it.
Very fun, yeah. Recommend it.
Join the adventure now.
So hopefully then you can kind of see that there is a tactile element to the board as well as the digital element that really brings people together as a group. And that's the whole point for us, is that there's loads of mental health apps, there's loads of things for young people, but they're all very individualized. They're very much about you and your phone and you tracking what you feel or doing a thing. And there is no way that you can protect young people's well-being or improve young people's well-being without thinking about that kind of social belonging and social interaction. And so for us, it's very much about the fact that they need to be building these relationships with other people. So this is a list of what staff working with young people want for them. So this is from conversations with clinicians, with teachers in hospital schools, play workers, health play specialists, youth workers, anyone who comes into contact with young people. They all have the same kind of wishes for them. It doesn't matter what their role is, how they're engaging with them. They want to increase inclusion. They want to see the young people more engaged. We have endless reports of young people just sitting in their beds on their own personal devices or coming into group learning settings and not engaging with people or with tasks and activities. They really want to build those kind of relationships with peers, particularly in healthcare. If you're someone with a long-term condition, if you can build a support network of other people like you, you know, they might not have the same condition, but they understand what it's like to have to come into hospital regularly or to be different from your friends. And that just doesn't happen at the moment. There's no kind of common ground for them to share. Emotion regulation is a really, really big one, particularly in alternative provision settings, but also in healthcare. Improved relationships with staff as well. So again, in order to help young people self-manage conditions, you need to be able to have really good conversations with them and get them to kind of buy into what you're saying. And that's really hard if you haven't already built a relationship. And then reduced isolation, because as I say, all of these individual young people at the moment are really struggling. So this is what staff want. And this is what our aim was to try and sort some of these things. So this is what's going on in the background of the game, or these are some of the models and frameworks that we kind of draw on, so that whenever we're creating content or we are thinking about how the game plays out, these are some really important things. So, bless you. The cognitive behaviour approach is probably familiar to some people. CBT is very well known. And this idea that our thoughts, feelings and behaviours are all linked, and that actually if we can change one of those things, it can have a knock-on effect and change other things. So that's kind of fundamental this one, I guess, is a bit unusual in that there's the cognitive well-being challenges in the game. So this is very much in kind of one realm of the game. So the way that plays out is that maybe one of the challenges will be kind of generating alternative thoughts. So the dragon came into this situation, they think this, you know, what are some other thoughts that actually might explain what's going on? So it's that idea to get people out of that rigid thinking pattern and to be aware that your thoughts are just thoughts, they're not reality. One kind of flaw with the cognitive behavior approach is that there's a lot of emphasis on faulty thinking and irrational beliefs. And some beliefs and some ways of thinking are not irrational. Some people have a really bad situation. Trying not to swear, we're online. So acceptance and commitment therapy is quite nice for those people who have had this awful trauma or actually do have a terrible prognosis. You know, there's no way you can go to them and go, actually, you're thinking really negatively about this. You need to think about this in a much more positive way. This is how we're going to reframe it. You know, so you can't reframe a negative prognosis always. So we also believe that it's really important to go, okay, what are your values? This is what you're dealing with. This is your reality. But let's think about your values and how do we want to move forward given how things are. And then finally, emotion theory. So we fundamentally believe that there are no negative emotions. There are no bad emotions. They are all pieces of information. So any emotion that you feel is a piece of information to tell you that you need to interpret, basically, to work out what's going on, how you need to behave, whatever. So, you know, an increased heart rate could be excitement or it could be anxiety. And the trick is learning how to work out which it is and then respond appropriately. And then obviously the next step on from that is being able to recognize that in other people, not just yourself. So I think it's really worth pointing out, because in lots of places we see kind of even wall displays about, you know, good emotions and bad emotions and go, ooh, that's uncomfortable. So those are some of our beliefs. And we have worked obviously with young people, but also with clinical psychologists and with educators all the way through to make sure that we are using relevant, evidence-based, validated models at all times and really kind of pick it apart and argue with each other about what's relevant, what's not relevant, what should go in, what shouldn't go in. So there's a professor of clinical psychology at Royal Holloway who we work with quite a lot, who is very experienced in adolescent development. So really looking at that kind of typical development timeline, I suppose, and how to build things into the game in that sense. This is part of the kind of iterative process then. So moving from the evidence that is underneath the game to the evidence that we need to gather to help us develop the game. Each little box is another bit of user testing. This is probably 4 years worth of work, maybe, on the board, and takes us up to about 18 months ago. So lots of co-design workshops and then the changes in between. So we redesigned the board completely. There was feedback that the game wasn't complex enough. It was a bit too basic. So we upped that. Then we did the kind of biggest academic trial. So what we found in that middle one is that there is an increase in psychometrically validated well-being, and that persists at the 1 month follow-up as well. But in those trials, there were horrendous Wi-Fi issues because, as we all know, schools and hospitals are not the best Wi-Fi areas. So we were like, yeah, this is great. It does improve well-being. Oh my God, no one can play it. So at that point, then we needed to do some thinking about that. And then we did some smaller kind of user research to refine things. And that brought us up to about 18 months ago, which is when we started a project with Innovate UK in the Mindset XR program. So a funded project basically to do pilots in healthcare to look at barriers and facilitators. So we know it works with young people. We know young people like it. They've designed it. And at every stage we've changed it based on, you know, what they want. We knew it improved well-being, great. But is anyone going to use it, and how would they use it, and what's going to stop them using it, and all of those exciting questions. So this is my job, basically, is to run these pilots. And we've spent 18 months working with all of these people to try to understand whether it's something they would use, whether it works in their setting, but most importantly, what needs to change to make it more useful for them. And so this is the point where I feel very judged following Lawrie's talk about doing pilots. We were very careful to, whilst it's very exciting to go, oh, we're being used in Alderhay or being used in Great Ormond Street, we actually were really wary that then lots of other places would go, yeah, well, that's fine for them, isn't it? Because they've got huge budgets and loads of innovation. So we have also been to Devon and Cornwall. And we have tried to work with lots of different teams. So we've worked with play teams and we've worked with hospital schools. In Alderhay, we're also working with the clinical health psychology team. Play teams and hospital schools, the sort of thinking was play teams are responsible for everyone under the age of 18 or in some places 25 within a hospital. So they go out to wherever those people are in the hospital. And similarly, hospital schools, anyone under the age of 16. We have learned an incredible amount. I knew we'd learn a lot, but we have learned an insane amount. Some of the things that we thought the game did or would do, or that people would think about it, have been affirmed. But then there's also been a load of things that who knew it might do that, which is really exciting. We've had reports of much faster integration, so particularly in alternative education provision settings where there are some kind of long-term students, but then students come in halfway through the term from other schools because they've had a particularly bad time. Often it's very difficult for those students to integrate, you know, into a class of 8 who've been together all year. And we had some amazing feedback about people who were in that situation. And actually, by the end of kind of 1 or 2 game sessions, they had all of these shared jokes and things they could refer to and were much, much more part of the class than had ever been seen before. Sounds like a grand statement, but it's true. And we've also learned a lot about the kind of the ward-based hospital school provision and some tricky things that we had no idea about. So, for example, parents being with the young people on the ward all the time can be a real issue in terms of delivering education or having tricky conversations. And the game has allowed the relationship between the staff member and the young person to kind of develop without that parent being part of it, which is often really, really important. So some amazing things, some excellent kind of feedback about, yes, we would use it. We want this, this and this, but the more exciting part is what didn't work. Because we're not here to just go, oh, they love it. Great. The Wi-Fi is still an issue. We know the Wi-Fi is still an issue. The Wi-Fi will always be an issue. And actually, because we knew that already, we had already started to kind of develop workarounds for that. We're trying lots of different things. And essentially, the ideal is an offline version so that you don't need the Wi-Fi. So that's what we're working to at the moment. Because of the unpredictability, so previously, most of the trials we've done have been in kind of community groups or schools where you had an hour and that was that and you played. Because of hospital environments being really unpredictable, the clinician comes in, the canyon needs to be taken out now, whatever it is, we realised that actually there needs to be the facility where you can pause the game and then carry on later. So currently, if you stop the game, it's gone. That's it. You have to start a new one, which had never been a problem until these environments. So now we are very nearly done with creating that kind of functionality so that if you need to stop for whatever reason, you can do. It turns out holding a phone at the angle you need to hold it at for the AR to track is really painful if you have a cannula in your hand. We, on a previous project, and with a different game, we'd use some kind of phone stands. they don't work for this because of the range of movement that you need. So again, what we're looking at with that is looking at a different way of setting up the tracking so that you don't constantly need to hold it in a really, you'll see when you play it, a really specific angle. Actually, the game kind of remembers where the board is and can generate it without that going on. And then the two kind of biggies were immediately, I remember I'd only been in the job about a month, I think. I was so excited. I'd got a meeting on the adolescent ward at Bristol Children's Hospital. I was like, oh, I've done so well. She's going to be so proud of me. And I rocked up with my lovely neoprene board and they went, ooh, what if someone's sick on it? And I was like, oh, it's okay, it's washable. And they went, no, not to our standards. And I was like, oh, no. And then I went back to the CEO and I was like, no. She was like, no, it's washable. Look, we'll put it in the machine, I'll show you. I was like, they don't care. Your washable and their washable is not the same thing. So we came up with all sorts of exciting ideas. My most exciting idea, which hasn't worked, was to vinyl wrap the overbed tables with the print of the game, because that would be a cool table anyway. The lovely people on the adolescent ward gave me some Koenig wipes so that when we went to the printer and got a little bit of the vinyl, and I sat there for several days just wiping it occasionally. That doesn't work. It comes off after about 10 wipes, in case you ever need to know. So that didn't work. So what we've got to at the moment is a very low-tech laminated piece of paper, which we are really disappointed in because we spent loads of time working on this neoprene board, but everyone in hospital is like, oh, this is great. And we go, okay, weird. And then kind of alongside that, they started playing it. This is great, da, 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 da. And then more and more we were getting people going, this is really good. But the people who need it most and the people that I'm finding it most helpful with are individual people. And actually, we don't have like a games room or a playroom, whatever. So we need it to fit on an overbed table, and this doesn't. And so we're going, okay. So now the current working model for that is we've got an A3 laminated board, which is fine, but the tokens are tiny, and so they go, and then you don't know where they are, and you can't move them. So these are the kind of things that you can't learn until it's being used in the setting without you there as a researcher, kind of managing it and make it all work. So this is where we are now. Basically, we are doing some stuff in the background with the tech to make it the connectivity okay, and we're trying to do some stuff with the physical assets so that where people do need the infection control compliant board, the pieces are not so tiny that you drop them all the time. It's not reflective, so the tracking works, and it can be bleached to within an inch of its life. So the Innovate Fund project, looking at those kind of challenges and barriers, facilitators, is coming to an end. We are now really aware that lots of people who find this really beneficial are working with young people who have got autism, ADHD, a range of other needs. And for some reason, it's really appealing to those young people. And lots of people say, oh, they love Dungeons and Dragons, and this is like Dungeons and Dragons, but it's got some good stuff in it that I can utilize, and I feel like I've achieved something with them, and they feel like they've had a great time. So we don't feel, I think this is coming back to, again, in the break, we're talking about I'm not a very good salesperson because I don't have a business background. I have an education and psychology background, which is not, you don't talk about money, you don't talk about needing to make sales. What some people would have done is go, great, let's sell it to those people. What we did was go, oh, we feel a bit uncomfortable about that because we haven't tested it really rigorously with those populations to design what they need or to change things that they need. So from September till December this year, we're doing some pilots in special educational needs provision, special schools, to make sure that we've really heard what those populations need from the game. But we are also working on a funded project. We are working with alternative provision settings, so hospital schools again, and other alternative provision settings, to develop a remote first version of the game. So at the moment you can play remotely, but it's really clunky. You need a phone or the tablet to do the game, and you need to be on a video call so that you can talk to the person about the challenge that you're doing, which obviously isn't great from a kind of digital poverty point of view. So this bit of funding, this project will allow us to work with those settings to develop the remote first, because another surprising thing that we learned was that there is a massive appetite for that. So both for this EBSA population that we talked about at the beginning, in the bedrooms, maybe needing to kind of reintegrate with their peer group and hopefully then do a sort of staged reintegration into a physical group setting through playing one-to-one with a member of staff online, playing with the member of staff and a couple of other people online, and then going, you know this game, you know these people, let's meet up in person and do it. But also in hospitals, we've worked with quite a few people who have said it's such a shame that I can't use it with that person behind those doors. No one's allowed through those doors, and that person's not allowed out of those doors. And actually, I could sit this side of the doors with my board, and they could sit that side of the doors with their board, but they don't have a laptop and a phone and a, you know. So for those reasons, we are going to try to develop this remote first version so that the remote play can be much smoother. Essentially it. If anyone does work with adolescents or knows anyone who works with adolescents who would be keen to join the community of practice, basically we meet for an hour once a month online, and we have different people come to talk to us. We focus on various topics, all suggested by people in the community. There are about 80 people now, I think, who come and share their ideas, discuss issues, whatever. Please scan the QR code or take a picture of it, send it to someone if you think it would be useful. And yeah, for people who are in the room, you can have go in a minute. Online people, that is, I'm afraid, the end all. No dragons for you.
Thank you very much, Claire. Any questions in the room? Lawrie?
Really interesting stuff. You kind of talked about not being business minded and sales minded, but like going forward, fast forward a couple of years, you still be blind. UK RI, they're funding.
Yeah.
Which sounds awesome. But, who are your investors?
So the dream is that it would be licensed by, I would have said ICBs, trusts, some NHS locations, whatever they're called, in 5 years' time, and local education authorities. So kind of commissioner level license, so that then it can be used within different hospital departments or different hospitals, and on the education side, any alternative provision setting in that county. That's the dream. Those people are incredibly hard to talk to. So as you said, all of the different stakeholders, those people are very tricky to talk to, in my experience. What we've had much more success with is the people who are working with the young people, the kind of front facing, I don't know what you call it, patient facing, but not in education. They are very excited. We've come across exactly the problem that you said, that at the moment people have had a free pilot. So the pilots that we've done have been 8 weeks long. We've had lots of interest in a much longer paid pilot, but always, oh, well, it'll be funded from the charity, which, as you say, is not a long-term kind of business plan. So yeah, licensing by commissioners is the ideal.
With that, could you see, sorry, took my hand like that. Could you see that going into other territories as well? So perhaps the US and perhaps having more of a commercial approach there, and that in turn being able to fund and further improve products and create other products and this sort of thing?
Yeah, absolutely. So we've really talked about that kind of Robin Hood model of where else could we go and sell it to then be able to take the time that the NHS takes to get into over here. For sure. Yeah. So we've been working with some various people in this area who have encouraged us to look at the US, because it is a much more straightforward way to do things. But also over here, there are various other groups of young people who definitely could benefit. And so I think it's really difficult, and it depends who gives you business advice about you need to focus on this tiny niche and go here, or actually do you broaden it a little bit because actually, yes, I might want to end up here, but the money's going to come from here. And so, for example, in this project, we found alternative provision because it's even hospital schools are run by local education authorities. They're not run by the NHS. So they happen in NHS settings, but they are funded by local authorities. And those settings and those organisations have been much, much more keen to talk about, okay, what can we pay for now? What's ready? What kind of license model is available? Whereas NHS settings are not there yet, shall we say.
So this is more of a general question, but so it's an educational game for adolescents. Do you know it's an educational game, or like is there a way that like you made it so that it's not obvious just because that might take the fun out of it?
Yeah, that's a really interesting question. So we were always trying to disguise it, and obviously I'm not a game developer. I feel like that is obvious, certainly from the conversations I had at break time. We have worked with people who are really keen on games and who are very anti the kind of educational side of it because that's not cool. And so we've always been quite keen to hide what's going on. Like, this is just a fun challenge. Let's just do this fun challenge. Yes, it's multiple choice and those, but we've always been quite good at, I think, not doing the sort of obvious, like, well, there's two bad things and a good thing. What are you going to choose? We put realistic options of like, are you going to take the drugs? Are you going to sell the drugs? Are you going to share the drugs with your friend? Like, what, let's be realistic. These are young people. Let's not go, there's one clear option that you should choose here. So I think we've always been conscious of that. But recently, it's been really interesting to work in these settings. People have come out of mainstream school. They know that they're kind of in a big intervention. And they've been saying things that make me go, oh, they know. And actually, they're okay with it. So one of them said, oh, this is a bit like the zones of regulation, but much better. At which point I was like, I need to know what that is. And another one said something about, I can't remember the exact comment, but there was a definite comment about the fact that they knew that this was trying to help them with something. And actually, I would have thought that they'd go, and so I don't want to do it. But their response was really good. They were like, oh, wow, finally something the teachers want me to do because this is what I'm supposed to be doing here. But actually, it's fun. So I think the answer to your question is it's not as well hidden as I thought it was, but it doesn't seem to be a problem. Yeah.
I thought it was interesting that it was popular with people who are neurodiverse. And I wondered whether you had theories on why that was. I certainly have some myself. But yeah.
Do I have any? Well, any of my theories will just be me lifting things that people have said to me in feedback. I think there's something really attractive about the kind of fantasy, magical. These are not people. They're not. And that was very early on. We had kind of people avatars, and people were like, oh, I can't personalize it enough to make it feel like me. This just feels weird. And so we really early on in the kind of code design process, we scrapped that. So I don't know what it is, but there's definitely something about the dragons, the fantasy side of it. There is also, and I can kind of see this with my own children, there's a real draw for neurodiverse people to have a phone so that they don't have to make eye contact. They can be like, oh yeah, look at that. And there's a real kind of shared, you don't do it with, with Monopoly. You don't go, oh, look at my chance card, look at my chance card, like that's boring. But because you're holding a device, which is part of the kind of social game that's going on, it's okay to look at your device. It's not like when you read a text message and you're then separate from the group. This is part of the group. And there's something about that which makes it much more accessible. But I would be very interested afterwards to hear what your theories are.
Well, that was definitely one of them. Yeah. Yeah, I'll talk later.
Probably got time for one more, just so you can have time to play the game.
Just one more question with the commercial as well. How do you think that this would fare, if you were to sell D2C direct to consumer, or in the mainstream in a commercial retail space?
So we have looked at that. Initially, we looked at that way back when. I think it feels uncomfortable for us because what we want is for it to be free for the user. But also, I think from a purely commercial point of view, because of the amount of work that's gone into it and what's going on in the background, essentially, if you sell it, you're selling it as a board game. And so then if you go and compare prices of board games, this suddenly looks very expensive because it's not just a board game. There's a lot going on. Yeah. So I think that's always going to be prohibitive. There is definitely appetite amongst families of patients that we've worked with who are like, where can I get this? I know it's only a pilot now, but I want this at home to play with this child and their siblings. But what we hope is that we can kind of get to that point through it being commissioned by NHS organisations to be used by patients and families or patients and their friends to kind of build their peer support groups.
Presumably you could then go and order a game through an NHS website or whatever, and that would be provided free as.
Yeah, so basically if the NHS has a license, it has a code and it can give any of its patients a code. The app is always free to download, but you can't do anything with the app unless you've got the board and stuff. So yeah.
Great. Well, thanks again, Claire.
Thank you.